Welcome everyone to Exercise Questions with Dr. Siddharth Prakash. My name is Ellen Hostetler. I'm a research program manager with the John Ritter Research Program at UT Health in Houston. I've probably spoken with many of you who are joining us here today previously, so I'm really excited to have you all. Questions about exercise and activity are some of the most common questions we receive. We know a lot of you want more information on that, so we're very excited to have Dr. Prakash here today. He's going to give a presentation, and after that, we'll have a question and answer session where you'll be able to ask anything about exercise or healthy lifestyle that you may want more info on. Feel free to type your questions into the chat or the Q&A during the talk. Also, I'll collect those so that we have them all together for him at the end. And also, please make sure you visit the John Ritter Foundation website for more information and to see recordings of these events. They will all be there for you to view. So I'll just introduce Dr. Prakash now. He is a member of the John Ritter Foundation Professional Advisory Board and a professor here at the University of Texas Health Science Center in Houston. He's also an expert on genetic aortic disease, and I will let him take it from there.
Thanks to Amy and Dr. Milowitz and everyone at the John Ritter Foundation for making this possible. I'm going to provide an overview today of the types of questions that individuals who are contemplating an active life should ask, and some considerations about exercise that may be important to your lifelong attempt to remain active. Some issues about exercise in people with aneurysms and dissections are frequently that there is significant uncertainty about the limitations and potential consequences of exercise, and that may in turn restrict physical activities after diagnosis and cause anxiety. Can we use clinical observations to identify rational limits to exertion for people who want to begin or maintain an active lifestyle? And in turn, can this restore confidence to engage in physical activities and therefore promote a healthy lifestyle? So the principles that I present to my patients about this are as follows. First, know yourself. Lifelong follow-up with regular surveillance is an important part of anyone's life with thoracic aortic disease. You need to understand the status of your disease in order to make informed decisions, just as you would to make informed decisions about a procedure. You need to learn about yourself. You need to take preventative measures that we'll go into, but a lot of those do involve blood pressure, because blood pressure is the number one risk for most people that causes increased aneurysm growth and potentially can trigger dissections. Second, you need to understand how your body responds to exercise. So know how the different types of exercise can affect blood pressure and understand your specific response to different types of exercise. And I'll show you some ways to do this. And most importantly, as anyone knows, because aortic disease is a lifelong disease, it changes over time. And so you need to be able to adapt to those changes by surveilling yourself and learning how to adjust for changes in your disease status. So many people ask me, how likely is physical exertion to cause a dissection? And it's important to put this in context. So dissections overall are very rare, and dissections that happen during intentional exertion are also very rare. Furthermore, we know that from interviews at Yale and other places with dissection survivors, we found that most people who had dissections were unaware of their diagnosis at the time of their dissection, and most have uncontrolled hypertension, at least 80% of people who present with acute dissections. Therefore, we conclude that being aware of your disease and controlling your blood pressure with medical therapies and other kinds of lifestyle changes can significantly lower your risk. And this is an important part of any preparation for exercise. And part of knowing yourself is knowing your specific risk to have a vascular dissection. This depends on a lot of factors, some of which are very disease specific. And so it's important to have a detailed conversation with your doctor about where your risk stands at any point in time. These risk factors that are well established for a vascular dissection include hypertension, smoking, your specific type of genetic mutation, whether or not you've had previous aortic surgery, and pregnancy, which is a major point in time of risk for women. So in all of these, because they're changeable, it's important to have updated information about them before you begin your exercise program. The reason why blood pressure is so important with exercise is that it is an essential part of your physical response to exercise. So that pulse pounding that you feel during exercise is actually distension of blood vessels. And with increased distension of blood vessels, the pressure on them increases. This means that if you have an underlying aneurysm or a thin aortic wall or other kinds of vascular risk factors, a dissection would therefore be more likely during exercise. And there are different risk markers to predict structurally which kinds of blood vessel problems may be more likely to lead to an increased aneurysm growth and dissection as a result of high blood pressure, which I'll go into. Therefore, before you start exercise, it's very important for anyone with thoracic aortic disease to control your blood pressure. The current guidelines recommend an ideal blood pressure of 120 over 80 millimeters of mercury, and anything above 130 over 80 is considered hypertension. The mainstays for treatment of these are two types of blood pressure medications, beta blockers and angiotensin receptor blockers. And in addition to that, you should follow up your risk factors and disease status over time. So for most people with thoracic aortic diseases, this means lifelong screening and surveillance, including annual checkups for your blood pressure, cholesterol, and other medical conditions. Medication adjustments as needed. Detailed imaging of your blood vessels, and the location may depend on the sites of your disease. And recognize and modify controllable risk factors, including hypertension. You can't control the genetic mutation that you have, but you can certainly limit the effects of that mutation by controlling some of these other issues. This goes over the mechanism of action of beta blockers and angiotensin receptor blockers that most people are prescribed with aortic disease, and it's important to understand their effect on exercise. Beta blockers work primarily by lowering sympathetic activation. Sympathetic nerves during exercise constrict your blood vessels and increase your heart rate. That leads to a rise in blood pressure. So beta blockers are particularly useful for exercise-induced hypertension and have actually been shown to have a disproportionate impact on blood pressure during exercise compared to blood pressure at rest. Angiotensin receptor blockers primarily work by limiting the action of hormones that affect blood volume and blood vessel contraction. And so they work equally well on resting or exerting blood vessels. And again, the overriding factor for most people with dissections is that they were not taking adequate doses of a blood pressure medication at the time of their dissection, primarily because most people who have dissections still are unaware that they're at risk for one until it happens. So how safe is exercise for people who have aortic disease? There are several clinical studies that indicate that moderate exercise is actually quite safe. The first set of studies were in people with abdominal aortic aneurysm, some of which were quite large, and they observed no ruptures in several hundred people who were undergoing treadmill exercise tests. There have been 3 large studies looking at cardiac rehabilitation and following patients who had acute dissections and cardiac operations after aortic repair, and those appear to be safe. These are monitored exercises in rehabilitation facilities. And more recently, in mice with Marfan syndrome gene mutations, moderate exercise was actually shown to slow down aortic disease. So what is it that distinguishes beneficial exercise from harmful stress due to physical exertion? It's the intensity, acuity, and dynamic component of exertion. And that's what I'll go into next. Depending on the type of exercise, blood pressure can respond very differently. And so it's important when designing your exercise program to take this into account. Dynamic or aerobic exercises generally feature slow rises in blood pressure, plateaus, and gradual falls in blood pressure over time. Rarely does blood pressure increase more than 150 to 170 millimeters of mercury in people who do not have pre-existing hypertension. Isometric exercises such as weightlifting, on the other hand, can have dramatic changes in blood pressure. In fact, blood pressures in weightlifters have exceeded 300 millimeters of mercury in some studies. The reason for this is actually that blood pressure is much less stable during isometric exercises than it is during dynamic exercises. Depending on the level of exertion and the type of breathing that is carried out during these exercises, people who are doing isometric exercises can have dramatic fluctuations of several hundred millimeters of mercury over a short period of time, generally with each repetition of a lift. And that means that repeated distensions and relaxation occur, which can dramatically increase the pressure or the force over time on the aorta. So the main differences are summarized in this slide. Blood pressure changes with isometric and isotonic exercises, where you're contracting muscles but not moving your body through space, are sudden and short-lived. That means that it's very difficult for us to track changes in blood pressure by, say, putting a cuff on someone doing isometric exercises, because there's so much interference and rapidity in the change of the blood pressure. There's a limited opportunity to adjust the intensity of exercise. You can work on breathing techniques and you can lift smaller amounts of weight, but it's extremely difficult to know whether that is effective in a given person. Aerobic exercises, on the other hand, have a gradual increase that is more readily measured during active exercise, a plateau phase where you can maintain a steady state blood pressure over time, and it provides ample opportunity to adjust the intensity of exercise before any threshold blood pressure that would be considered dangerous may be reached. This is a chart that illustrates the dynamic or aerobic versus static or isometric components of different exercises. And generally, being in the lower left corner of this curve, of this plot, is low intensity, whereas higher intensity increases with the vertical and horizontal axis. You can see that most exercises that would be considered high dynamic, high static exercises are extremely vigorous types of long distance endurance exercises. Whereas many common activities can be accommodated into this lifestyle. Now, in addition to the pattern of rise of blood pressure, the overall number actually makes a difference. This is a study looking at many thousands of individuals who exercised on a treadmill and measured the maximum change in their systolic blood pressure during a moderate phase exercise. It turns out that people who had higher blood pressures during exercise actually had higher cardiovascular mortality. These were not individuals with aneurysms and dissections, but this kind of pattern has been pointed out many times over the previous 3 decades. This means that exercise blood pressure can actually predict future cardiovascular events, and is one reason why we use it to stratify patients in cardiology for their potential need for medications or interventions. And it's also important to know that the exercise blood pressure in these studies is completely independent of your resting blood pressure, which is often normal. These were not patients who had pre-existing hypertension, but they became hypertensive with exercise. An example of that is shown in this slide, where we put a patient on a treadmill on the top here and ask them to gradually increase the speed and the angle of the treadmill. Over time, they developed severe hypertension, whereas at rest they were normotensive. This indicates profound exercise-induced hypertension, and that hypertension can actually be prolonged even after you stop exercising. Normally, we expect blood pressure to fall off, but in some individuals, it remains high even 30 minutes after exercise. This means that they're exposing their aortas to excessive and long hypertension, even if in between their blood pressure readings are normal. Now, we can also measure the propensity for this kind of effect by doing resting blood pressure measurements using a specialized system that measures vascular stiffness. Vascular stiffness means that your aorta and other blood vessels are thick and stiff like a pipe, and they don't expand and contract. What that means is that as the blood pressure wave travels through the arteries, it travels faster, and it can actually collide and amplify with previous heartbeats. That actually increases the overall pressure in the system. It's kind of like this. When I'm moving the arrows together, these two waves go into one, and that actually increases the amount of pressure that the artery experiences. So with those kind of measurements, we can predict those patients that might encounter this kind of dramatic rise in pressure during activity. Now, there are three important considerations for blood pressure during exercise: the maximum pressure experienced by the aorta, how quickly blood pressure rises during exercises, and how long your pressure stays at or near the maximum value. We know that prolonged exposure to pressures over 140 millimeters of mercury is considered a risk factor for new dissections or progressive growth of aneurysms. Therefore, minimizing the time that your pressure peaks is one goal of a responsible exercise program. So there are some practical steps you can do to make this possible. First, limit repetitions to avoid fatiguing, because we know that when you're close to fatigue and are unable to do another repetition, your blood pressure can dramatically increase. Avoid straining your chest or abdomen, because that can skyrocket blood pressure. Pursue moderate, not strenuous exercises with primarily aerobic, not isometric or isotonic focus. And instead of interval training, focus on a steady, moderate tempo. In that scenario, we know that blood pressure may rise early, but then plateaus and even falls in most people. Now, this is an example of some vascular stiffness measurements in people with and without dissections. So this is a relatively normal flow pattern. When we're looking at the stiffness measurements, there's little augmentation. That is, the pressures are relatively normal inside the aorta. This individual, however, a 26-year-old woman with vascular EDS who had previous dissections, even though their overall pressures are lower, actually demonstrates pronounced augmentation of the pressure wave inside the aorta. This indicates increased stiffness and augments blood pressure responses, meaning that her peaks are higher and her valleys are lower in her blood pressure, which can indicate a predisposition towards exertional hypertension. So in order to combat hypertension and aortic disease, we really have to look at all three of the principal components. That is exertional hypertension, ambulatory hypertension, which I'll get into in a minute, and the component of vascular stiffness. So what is the composition and stiffness of the blood vessels? And we must measure and treat all three to improve outcomes in high-risk patients with vascular diseases. So in our clinic, we advise people to minimize the isometric component of whatever exercise they're doing. And that generally means avoiding maneuvers where you're bearing down, like you're having a bowel movement, or feeling stress in your abdomen or chest. We recommend daily light to moderate aerobic exercises. The current cardiovascular recommendation for fitness is 30 minutes, 5 to 7 days a week. But what about people who want to engage in more intense exercise regimens, or even do some training? There are special exceptions for people with neck and groin aneurysms and dissections, because many times these are particularly sensitive to torquing or twisting movements, and certain types of exercise like prolonged cycling have been shown to increase stress in these areas. And so we recommend avoiding chiropractors for neck and upper back pain because of the potential danger of manipulating neck blood vessels, and avoiding cycling, prolonged cycling maneuvers in people with iliac artery dissections because of the twisting motions involved. Some people have suggested recumbent cycling as an alternative, but this has not been shown or demonstrated to have a long-term effect yet. Now, in our group, if we have individuals who want to engage in more strenuous exercise, we put them into this protocol. First, a history physical in order to assure them that they don't have any limitations that could prevent them from completing their exercise. This would include a genetic evaluation to make sure that we understand the cause of their disease if they have a gene mutation. We do underlying workups of their blood vessels, including measurements of vascular stiffness and cardiac disease, and of course, evaluation for baseline hypertension. In our clinic, this is with an ambulatory blood pressure monitor that can give us many more data points for determining if someone actually has hypertension than the clinic blood pressure. We also make sure that we have up-to-date imaging to assess the status of their aortic disease. And if they wish to engage in more vigorous exercise, we put them on a treadmill to measure their blood pressure and detect exertional hypertension. After all of this, we're able to come up with the targeted exercise prescription, and then we can revise this over time as their fitness changes. So this indicates that our current strategy is to test patients' blood pressure responses in real-world types of exercise that people are likely to engage in at home or in the gym. We have them fill out a questionnaire to obtain their medications and weekly activity levels. We measure their blood pressure by using an ambulatory blood pressure monitor at rest and during a series of 5 exercises, 2 measurements per exercise, and then at rest in between the exercises. We do bicep curls, hand grips, 6-inch leg raises, wall sits, and stationary cycling. And we measure their blood pressure during recovery after the circuit to determine how long they may remain hypertensive. So we enrolled so far of our first 50 patients, and I'm going to give you a summary of what we found. These were patients with thoracic aortic aneurysms or dissections from our clinic at the University of Texas at Houston, and healthy controls that were age and sex matched. We excluded those under 18, people with uncontrolled hypertension at rest, which we defined as a systolic pressure greater than 160, people who have had recent myocardial infarction, strokes, or aortic surgery, because we wanted to make sure that they were healed and fully capable of exercising at their baseline, and anyone who was unable to complete the exercises in the circuit. So in total, we analyzed 31 subjects and 14 controls so far. We found that 6 of our patients, of our 31 patients with thoracic disease, had systolic blood pressure measurements exceeding 180 millimeters of mercury with exercise. The most common exercises where this occurred were wall sits, hand grips, and biceps curls. And again, wall sits being a prominent Valsalva maneuver, meaning they were clenching their abdomen and pelvis in order to do that exercise. And as we mentioned, that is strongly associated with blood pressure increases in any kind of isometric activity. The patients themselves rated the leg raise as most difficult, along with the wall sit. And that corresponded in general to higher blood pressures during those exercises. We did find that baseline moderate activity levels per week strongly correlated with blood pressure responses to exercise. In fact, all of our patients with hypertension during exercise had less than 1 hour a day of activity. And so that is indicative of the effect of training and activity over time that it can actually blunt your hypertensive response to exercise if you have it. So this correlates with other studies showing that with increasing fitness, you're less likely to develop hypertension with exercise. In looking specifically at people who had survived aortic dissections, we did note that their exercise diastolic pressure measurements were lower than those who did not report or did not have a history of hypertension. And we think this is related to increased vascular stiffness in the subgroup. There was, however, no significant difference in the variability between measurements of the same exercise in people with dissections. We had hypothesized that this would indicate fatigue and a reduced capacity to exercise, but we did not see this in this circuit of exercise with our patients. And there was no significant difference in the ability of people who have survived dissections to complete the exercise protocol. So we also submitted a survey after the study to people who had done the exercise program, and half of our respondents said that they're more confident in their ability to safely complete exercises they had previously hesitated to do. 2/3 say they would do it again, and 3/4 said that they learned a lot about themselves from the ambulatory blood pressure measurements. So again, knowledge is power, and in this case, it does seem to have some effect on people's overall confidence and ability to go out and do exercise, which is really, if nothing else, the overall goal of our approach. So we saw no significant difference in blood pressure increase in exercise with patients compared to controls. Again, we found a strong correlation between increased moderate activity levels and a lower likelihood of developing hypertensive responses to exercise. Overall, we conclude that most people with aortic disease can safely and effectively perform moderate intensity exercises in our study. Thank you very much. I think I'm done.
Okay, so let's look at some questions then. We had a bunch sent in during your talk. So first of all, people were very interested in that chart you showed with the different exercises and the different quadrants. They want to know, is this available somewhere so they can print it out maybe and keep it on their refrigerator? And secondly, there were some questions about specific, looks like there is a little link down there that maybe folks can take a screenshot. We can have Meredith maybe send it out after the session too, so you can find this for yourself and keep it handy. Some folks also had questions about specific things that might be missing from this. Kayaking in particular came up.
Kayaking is here. It's right here.
Kayaking is there. It's there. Yes. Okay. So kayaking is there. We also have a question about snow shoveling. Excuse me.
Right.
I don't know if that's
snow. Well, snowboarding is here. Most of the time, snow shoveling and other kinds of snow activities are rated as pretty strenuous, particularly if you're not doing them regularly. So the key here is habitual, right? If you are a habitual performer of these exercises, it will be much safer for you than if you were to do them once in a vigorous fashion after being sedentary. So the context really matters. These are general guides, but in general, if you're starting doing something, you should do it at a very low level because we know that fatigue is much more likely. And again, if you do something until you're fatiguing, no matter how experienced you are with it, you are going to run into trouble with blood pressure. We know that from our study because the people who were fatiguing, even with moderate intensity exercises, are the ones that really encountered trouble with those hypertensive responses, the blood pressure shooting up.
Great. And then for tasks that might not be exercise, but still require exertion, for example, picking up your kids, carrying around groceries, everyday life, things like that, would you say those fall into one of these categories here? I know people have, especially the picking up your kids. I hear that a lot as a worry for people who, want to hold their little ones or even their grandkids.
I mean, I think that the endorphins you get from picking up your kids will definitely counteract most stressors that you're feeling. I mean, if you're feeling happy and relaxed when you're doing it, then I would say go for it. The real question here is, are you really under stress when you're doing it? Does your body feel stressful? Are you anxious? Are you concerned about it? And those are the things that we know raise your blood pressure. So it's going to be a combination of your mental state and you're feeling physically tired when you're doing it. If you feel like you're handling it okay, there's no problem with these daily types of activities.
Got it. Okay, so we did have a few folks who, speaking about doing things regularly versus one-off, talking about long-term exercising, such as being a distance runner for 10 years or exercising on a bike, perhaps. Those are often lifelong sports people want to engage in. Are there benefits to long-term exercise as well as the potential risks? How do we kind of look at the long-term picture rather than just, am I going to have a dissection at the second that I'm running? Or if I run for 10 years, is that overall helping more of my health than not?
So we know that there is a dose-dependent decrease in cardiovascular mortality for people who exercise, beginning with even a small amount of exercise per week. So compared to no exercise, even people who do 30 minutes a week live longer and they have fewer cardiovascular events like heart attacks. So we know that exercise, even in small doses, is good for you. And the longer you do it, the more it's kind of a cumulative effect. So the total number of minutes really does matter. And so that's why we found, I think, that blood pressure was worse in people who exercise less or are less active. And I think that would definitely translate to someone who is doing something at a high level for a long time that will set them up for a lower cardiovascular event rate. And in addition to that, it's going to make them much more resilient to any changes in their disease status because they will have lower blood pressure. They will probably have other cardiovascular fitness indicators that are also healthy. And again, those risk factors really do modify the course of the disease. So they're controlling them effectively. They're going to also have a better disease course.
We have some questions about kind of trying to do a study on yourself the way you've been doing it, measuring your own blood pressure before exercise and after. Is that going to give you any information? If the answer is no, is there a way folks can basically get what you've done for folks locally at their own geographic locations?
Well, there's nothing magical about what we're doing, but it is difficult to measure blood pressure accurately during exercise. So I understand that people want to measure it before and after. The after is really important, actually. So I would encourage people to measure their blood pressure after exercise, primarily because we're going to collect the group that has prolonged hypertension after they stop exercise. And that can indicate significant exertional hypertension. So if you spot that is never normal. In most cases, when you've exercised at moderate intensity specifically, your blood pressure should actually drop relatively quickly after exercise because all that blood is going to your muscles, right? And it should really cause relaxation of the blood vessels to allow blood flow into the muscles. If that's not happening and you're very hypertensive, that can be very detrimental. So it is something that you should report to your doctor.
Okay. We have a few specific questions that I'm just going to read quickly and hit you with. Someone who's previously had repaired their ascending aorta, they now have dilation in their iliac arteries. Sounds like they are an avid exerciser doing 30, 40 miles a week of running. Is the new diagnosis of other arterial dilation a problem with that running schedule that they've already been doing?
Right. So running is not considered to be a super high risk for iliac. Again, the main thing that we're interested in is torque. And so let me go back to that slide here. So if there's a significant angle between the body axis and the legs, that's where the iliac arteries get twisted and compressed. That's why cycling has specifically been shown to affect the iliac arteries. Even in people who have no underlying aortic disease, there have been cases of dissections related to prolonged cycling. There is no such relationship specifically for running. Obviously, if you have a highly deleterious gene mutation and an aggressive disease, any sort of stress can do it. But there's nothing to say specifically stop running to reduce your risk here. So I think they're fine to continue their running. Again, checking their blood pressure and making sure everything else is controlled is always the goal.
Sure. Okay, we've got another avid exerciser here who says they've been exercising about 6 months, and just as you noted, they've reported that their resting blood pressure has gone down due to that habit, which is wonderful. But they're wondering if spikes above 140 are to be avoided at all costs, even if these are brief spikes during their training that they're doing overall. If most of it is in the safer zone, is doing a sprint maybe at the end of your 3-mile run and briefly going up high, is that something that necessarily always needs to be avoided?
No, I didn't say avoid, I just said minimize. So the key is to minimize the time that you spend near the peak of your blood pressure. And that it is impossible to avoid your blood pressure going over 140 at times. Everyone will have that. But if it's brief, if it's transient, then there really isn't. I mean, there is incomparable benefit to the exercise, and it far outweighs any very slight risk to transient changes in your blood pressure over 140. So I would not worry about that. It's really the prolonged hypertension or doing things where you're inducing severe hypertension with exercise over 180 to 200 that could be a concern in the long term.
A few other specific exercises, bar class, which actually we were just discussing before this. We went live here. That's similar to yoga and Pilates, so perhaps in the same zone as that.
It's excellent. I mean, I think that a lot of people who have doubts about exercise can get into this. It's it's a great environment. A lot of times it's very encouraging. And you can start out at many different levels. You can find your own level and really take it from there. So I think that's something that really encourages people to be active, and I strongly support that. It can take many different forms, but I think that would be a great alternative for people.
Okay, fabulous. And let's see about other exercises. Strenuous yoga, which maybe I'm guessing is heated yoga, or where you use weights or something with it.
I mean, it really, it's very hard to define strenuous in terms, in those terms. When it comes to aerobic exercise, we have heart rate zones, and we typically tell people to stay below 80% of their age-adjusted maximum heart rate, which is 220 minus your age. That's considered the moderate zone. For yoga, I'm not really sure what the equivalent would be. I need to educate myself about that. But the weights would be problematic potentially, depending on what stage of disease you are in. If you had a dissection, you might need to avoid, the Valsalva maneuver, which is, as we talked about, is bearing down in your abdomen and chest. And those movements can increase pressure directly on the aorta and raise blood pressure. That would be the chief concern there.
Okay. This is a really great question. How soon after aortic dissection or surgery to repair an aneurysm is it okay to start exercising, and when should you start to monitor your blood pressure and do these sorts of things?
Yeah, so after repair in particular, or dissection, I strongly favor doing a supervised exercise program. So unfortunately, not everybody can get access to cardiac rehabilitation. But if you can, cardiac rehab is actually a great environment to start exercise after a traumatic event like a dissection, because you'll be supervised. You can get advice on what kind of dissection, what kind of post-dissection exercise may be appropriate for you. And you can actually get blood pressure monitoring that occurs during most of those exercises. So that is a great way to start out, and it gives you a lot of information about yourself that you can then use to take home. If you don't have that, I recommend starting with light to moderate aerobic exercises as soon as you're cleared by your doctor. And so that can be walking. It can be you're walking on a treadmill if you don't want to be outside. Sometimes, depending on the location, they'll let you do light cycling. And then gradually ramp up the activities. It's really important to start low and gradually build up what you can do so that you're not exceeding your stamina level at any point in time, because that's, again, where you get into trouble with hypertension.
Okay, we have someone here who's made a comment, but I'm going to change it into a question for them. Talking about using beta blockers, this person seems to be worried about passing out after exercise if their heart rate increases past a certain point. Is this a worry?
Well, with beta blockers, it would actually be less likely that your heart rate is going to increase at least to the level it used to, because it tends to blunt the heart rate increase with exercise. Sometimes people do feel lightheaded after exercise, and that's related to this phenomenon that I talked about of vasodilation or enlargement of the blood vessels after you stop. And that can last for several minutes, where your blood pressure actually drops and you can feel dizzy. That actually is not unusual, and it's far better than the alternative, which is to have high blood pressure after exercise. If that happens, most people can recognize that and just sit down and rest and put their head between their knees, and it will get better on its own. if that's more likely to get worse, not by beta blockers, but by other antihypertensive medications like losartan, which actually would lower your blood pressure more severely than beta blockers.
Okay. Thank you for clearing that one up. We have someone who's commented they have a ACTA2 mutation and they have not had an event yet, but they know obviously they're at increased risk for dissection due to their mutation. They are not on blood pressure medication. Would it be beneficial to go on blood pressure medication even without a diagnosis of hypertension to give yourself more space, I guess, to during exercise or exertion? If you're extra low to start with, then you have more space to work up to a healthy exercise level.
Yeah, so the use of prophylactic medications in people who are carrying mutations but have not had any evidence of disease yet is still controversial. However, I strongly believe that you should consider doing it, particularly if you're active, because as I mentioned, beta blockers can help blunt the exertional response of blood pressure to exercise. And the more active you are, the more benefit you get from the beta blockers. So if you are living an active lifestyle, that actually can help you more than anything else. And we also know that beta blockers are protective for people with aortic disease. So even if you don't have any evidence of aortic dilation, I think that it is reasonable to start beta blockers.
Okay, that's very helpful. Okay, we have someone who just is looking for a little bit clarification on something you mentioned about the equation to find your heart rate. I'm not exactly sure. They say your age appropriate heart rate. Is that referring to your heart rate or your blood pressure when you did the 120 or 220 minus your age part?
That's your target heart rate for the upper limit of the moderate zone of exertion. So the heart rate zones are based on your 220 minus the age formula, and then 50 to 80% is considered that moderate zone of that number. It's a rough guide because I should point out that obviously if you're taking a beta blocker, it's not going to be the same because beta blockers will lower that maximum heart rate during exercise. So for that reason, I don't emphasize heart rate zones for my patients because I don't think that for many of them, it is really that accurate. This is not for people who are on beta blockers.
In that question, I guess, the ambulatory blood pressure monitoring you talked about, can people buy those and have them for their own at home? Are they incredibly expensive? I know that when you loan them out to your control subjects, we were told to give them back or pay the consequences.
Yeah, so the ambulatory blood pressure monitors we use cost about $2,500 each. They're really expensive, and the reason they're expensive is because they're optimized to work under a lot of stressful situations. So if people are moving, it's often really difficult for a normal blood pressure monitor to record a blood pressure because you have to be completely still for most of those. And of course, you can't be that when you're exercising. And even with that, we often have to have 2 or 3 people hold the arms of our patients still to get good readings during different exercises. So it is not something that just anyone can do. And even if you did get a blood pressure monitor, it would be hard to get accurate readings during exercise.
Okay, this is not exercise specific, but I say it falls under healthy lifestyle. So, and it's a question that, again, is asked often. Unfortunately, I don't think we have a ton of good evidence to share, but nonetheless, love to hear your thoughts about diet, supplements. I hear all the time about people saying, I'm at risk because I have this genetic mutation or family history. Can I take collagen? That seems to be the hot supplement these days because collagen disorder, maybe that will help. Specific diet to recommend. People just want to feel like they can do something to help prevent this disease if they know they're at risk.
Right. So the common misconception about supplements is that they get anywhere near your aorta. So when you ingest a supplement, the First of all, it gets digested in your stomach into its constituent amino acids. Amino acids are the building blocks of protein. And so your body doesn't know the difference between those amino acids and any other amino acid you eat, right? So you can get the same amino acids from regular food, in other words, but you're paying a lot more for the supplements. So that's what I tell people, that once it goes into the stomach, there really isn't a huge difference. Collagen in particular, from there's just no way that that's going to be any more effective than regular food.
Got it. And we do have someone commented that they were able to work with a registered dietitian after their dissection, which I think is a great idea if you have that available to you. Okay, someone is asking about ARBs versus ACE inhibitors. I know that we have we've done some research on that in our lab, so I'll let you address that.
Yeah, so we generally prefer ARBs over ACE inhibitors because there have been some studies. Again, primarily these were retrospective clinical studies, not randomized trials. So there's always the chance for bias, but an observation of faster growth and some potential increased risk for dissection in people on ACE inhibitors. We've also observed that in animal models with gene mutations that resemble those of patients. So we caution people against using ACE inhibitors to treat aortic disease. Obviously, a lot of our patients are on them anyway because they might be taking them for another reason, like blood pressure. But if that's the case, I usually switch them from an ACE inhibitor to an ARB.
I think we're hitting a lot of them. Let me just see if I made any other notes. If you're given a weight limit by, let's say, your surgeon, they say no more than 10 pounds. Can you work up from that if you train for it? Someone's commented that they feel like they can't do their daily life activities with the weight limit that their surgeon gave them.
Yes, so I once had a 250-pound man who had told me that his surgeon told him he couldn't lift more than 10 pounds. He said, I can lift 10 pounds with my pinky. So
arm probably weigh that
much. So we say you can lift whatever weight you can comfortably lift without having to bear down or do that Valsalva maneuver. And that is kind of a useful metric for most people because it can be a very different number in absolute terms, but it kind of defines your personal threshold. So I know that there's a huge emphasis on numbers because we need them for these letters that we write to employers and so forth. And that's fine. But in real life, it doesn't work that way. And you have to live your life is what I believe. So lift whatever you can lift comfortably without bearing down, whatever that number is. And if you do that regularly, guess what? That number is going to go up because you're going to get stronger. And then you've gradually increased your threshold. So that also works great as a self-motivating tool. Right? Yeah. You can do it more often and get stronger at it.
Absolutely. Okay. Someone's worrying about a low heart rate. So maybe if you're on medication, if your heart rate's below 50 in this example, is that a concern, a good thing? Is it extra good?
Well, it's not necessarily extra good, but if you're not having any symptoms from the low heart rate, then it is perfectly acceptable in many cases to be on that dose of medication. Now, by symptoms, I mean, if you're so tired you can't get out of bed, if you're feeling lightheaded and like you're going to pass out, if you see black spots in front of your eyes, then your dose is probably too high. And you need to tell your doctor because we don't want you falling and hurting yourself. But if you're walking around and feeling perfectly normal and you don't have mental fog and you're feeling energetic, and your heart rate's 45, that's fine. I mean, I have plenty of patients with their heart rates in the 40s long-term, and they do everything they need to do. So it's really just a number. It's just like the weight. It's different for different people.
Okay, and then one of the last few here, and maybe I'll just generalize it so more people can benefit. For folks who do have a known genetic mutation in their family that's putting them at increased risk, when children are identified at younger ages, how can we balance potential risks in the future with the fact that they're kids and want to play sports and run around with their friends and not be different? And if they don't have disease currently at their current age, can they participate fully in life, or do we need to restrict them?
Right. Well, I should preface this by saying I'm not a pediatric cardiologist, so I don't deal with this question. I know it's a very difficult question and fraught one, and I have tremendous respect for the people who make those decisions. I would say that the clear red line is in terms of contact sports. So external contact, in particular, traumatic contact, is probably not a great idea if they have a family history of dissection. And especially if they're showing some signs of disease. If the rest of it is really contingent upon the bottom line is expert opinion, and there isn't a lot of evidence to go on. But we can say that, as I mentioned at the outset, exertional dissections are extremely rare, particularly in the pediatric population. So that is the good news. And I know that they are continually revising the guidelines to make them more flexible, because a lot of the early ones just said no sports of any kind. And I know that they're more liberalized now than they were a few years ago. So my hope is that will continue.
Yeah, hopefully we can get some better information to give people more confidence about making that for their kids. Okay, we've got a new one here for someone who has started their exercise program. It sounds like it's going great. They lost 25 pounds, brought their blood pressure down to sub 120, and their cholesterol also dropped. Is it reasonable to resist medical therapy for blood pressure and cholesterol, given that they've had success? They have bicuspid aortic valve and TAA. I don't know if they meant thoracoabdominal. I assume they meant TAA, but sure. Aortic disease and BAV. But they've done pretty well in this exercise regimen.
Right. So we
he clarified. He's got an ascending aneurysm.
Ascending aneurysm. Okay. So we actually have clinical tests to determine whether or not you need to be on a statin for cholesterol, for instance. And it really depends upon all of the risk factors that we can measure in the office. So there are objective standards as to whether or not he may benefit from a statin and can stay on it. It's actually a calculator that we share with doctors to make the process really easy. So his doctor should be able to figure that one out. In terms of blood pressure, if I recommend that anyone with a thoracic aortic aneurysm, as I mentioned before, is on at least a beta blocker. And the reason for that, particularly with ascending aneurysms, is because beta blockers profoundly reduce the wear and tear on that ascending aorta. They reduce the force of heart contraction. They reduce the distension of the ascending aorta with each heartbeat. And as you can imagine, that's the major lifetime stress that people have. It's the number of heartbeats you have. They also slow the heart down, so you're spreading them out over more time. That's why I think it makes sense to stay on the beta blocker, even if you don't have high blood pressure, but maybe at a lower dose than you would have otherwise.
Hopefully that helps. Feel free to write in if not, person who's been commenting. Okay, we've got a question that I actually hear a lot from folks who ask me and have not asked their doctors this. What about sex after dissection, or if you're at risk because of an aneurysm or genetics? Are there specific limitations to that? I know it's in your little chart now.
In my chart. I got put there very early because so many people asked me. Sex has actually been studied in terms of the metabolic equivalence, or METs, and it is considered a low impact activity. Now, some people it may differ, but in general, it's not considered a high risk activity. So anyone who has had a dissection survivor or with an aneurysm or genetic predisposition can engage in sexual activity and really does not need to be concerned about the consequences. It is, for their aorta, it is considered to be a low risk activity.
I noticed that you had written it in there.
I wanted to make sure I mentioned that one because I know somebody was going to ask about it.
Yeah, absolutely. I don't think it's in the Marfan one, so perhaps.
Yeah, it needs to be put in there in the next version, I think.
Yeah, absolutely. Okay, I think, let me just scroll to the bottom, make sure I'm not missing anyone. And in my notes, let's see, we did kayaking, snow shoveling. I think that might be pretty much it. If I missed someone, I apologize, but they were coming in fast, and I think we pretty much got everyone. Oh, skiing. Is this considered an isometric exercise? I'm guessing downhill skiing.
Yeah, so downhill skiing is up here. It has both static and dynamic components. It's kind of in the middle here, but it's pretty calorically intense. So again, it really depends on the kind of skiing and the frequency. If you're a habitual skier, you skied all your life, you ski easily without effort. That's very different than if you ski once every 10 years and you decide now is the time you're going to hit the slopes. You can really put your body under tremendous stress if you're doing a new activity at a high level. So that's what I would say avoid doing in general.
Okay, someone is asking, I know we talked about this quickly, but maybe they joined late, snow shoveling. Again, this perhaps because we're going to fall now, people are realizing.
I guess people really are looking forward to the cooler weather.
Yeah, I guess so.
Yeah, snow shoveling, again, maybe not a great idea if you haven't done it in a while. You might want to at least not do as much as you would have otherwise. But overall, these are things that it's really a common sense kind of judgment call, depending on your level of activity and your physical fitness. If you feel like you're able to do these things without straining yourself and without feeling exhausted, then I think it's fine. But if you feel like this is an unusual big ask for you, then you might want to get some help with it.
Okay. And then we just have 1 or 2 minutes left. So caffeine, coffee, is this a danger?
No, not in the sense that it's going to trigger a dissection. There's absolutely no evidence of that. In fact, there is some evidence that habitual caffeine drinking, that is 2 to 4 cups of coffee per day, for instance, can actually lower blood pressure and have some beneficial cardiovascular effects. I don't recommend that my patients drink coffee, but I certainly don't tell them to stop.
Okay, and then alcohol consumption, obviously there's a level that's not safe or healthy for anyone, but I assume they mean moderate, casual, social alcohol use.
Yes, more than 3 to 4 drinks a week of alcohol has been associated with hypertension. So again, that being the number 1 risk factor for aortic disease, you should really keep your drinking to a moderate level, and definitely no binge drinking.
Good advice for all. Okay, and then I think that is it, and we are just at time there. So thank you so much for answering all of these questions. I think there's a lot of people in here who are saying thank you and they got a lot out of this. Someone wants to ask about commercial space travel now that Jeff Bezos and all are going into space, but I assume that's a joke given their smiley face. So I think a lot of people have really benefited from this because I know I hear from so many who get conflicting info from cardiologist, surgeon, geneticist, genetic counselor, that this is distilled in one place going to help a lot of folks. So appreciate very much your time and everyone for joining us today. This is recorded, so if you go to the John Ritter Foundation website, probably tomorrow, it'll be up by then. You can see all of the sessions that we've done throughout the week. So really encourage you to look there for more information and share this with your family or friends who weren't able to join today.
Thanks, everyone. It was an honor to take part in this.